All right, let's talk about deep vein thrombosis. So first, let's start with what is Virchow's triad here. So stasis, patient sitting in bed, endothelial damage, maybe trauma, and coagulopathy. So these three things are going to be bad. So we have your inferior vena cava here, your iliac veins, and then I have a question for you guys. Is the superficial femoral vein a deep vein or a superficial vein? So it's kind of a trick question. This is actually considered a deep vein. So say you develop a deep vein thrombosis in your superficial femoral vein because you're a trauma patient and you're stuck in bed because you have bad extremity fractures or pelvic fractures. And speaking of pelvises, your pelvis is here. These big deep veins, the iliacs, are going to house big nasty thrombi that can cause fatal pulmonary emboli, okay? And the thing is we don't catch those on regular screening venous duplex ultrasonography. So if one of these bad boys pops off and goes all the way up into your RA, then into your RV, and then gets stuck in your pulmonary artery, or worse, a branch of it, or worse, a saddle embolus, this could be lethal and typically would cause a PEA arrest, okay? So how do we combat this? Well, we put everybody on DVT prophylaxis, chemoprophylaxis. So the trauma dose, we like to use low molecular weight, Lovenox, and we do 30 twice a day. That's the trauma dose for 99.9% of trauma patients, unless, of course, they have a bad traumatic brain injury. And at that point, we use what's called the Byrne-Norwood classification to help us better understand when and when we should not initiate chemoprophylaxis for DVTs in traumatic brain injured patients. But we're always concerned about causing a fatal PE in our patients. And if we truly can't put them on any chemoprophylaxis, then we can place what's called an inferior vena cava filter in the inferior vena cava that'll go just below the renal veins here to protect us from a fatal PE from a deep vein thrombosis.